Good evening to all. And today I'll be talking about electrical storm. So, electrical storm, basically what it does, it refers to a state of cardiac electrical instability. There are multiple definitions, sometimes confusing also. However, the underlined theme in all of these definitions is that there is a generalized myocardial electrical instability. Like there can be multiple episodes of ventricular tachycardia or ventricular fibrillation within a short period of time.
Anupam, do you have slides? I think your slides are not visible.
Not visible?
Yeah, it just shows your desktop, the folders.
Then I will reshare.
Yeah, please.
I already shared, but then I will reshare. Now is it visible?
Yeah, it's visible, but not full screen. Not presented.
No, only. Yeah, I'll go to full screen now.
It's full screen and visible now.
Okay, thank you, sir. So electrical storm basically refers to a state of electrical instability. There is a generalized myocardial electrical instability. There are various definitions to define an electrical storm. Maybe we can consider multiple episodes of VT, multiple episodes of VF within a relatively short period, typically 24 hours. However, incessant VT is a little different. It is a hemodynamically stable VT, which is lasting for longer than 1 hour. And in patients without an ICD, the electrical storm has been defined as occurrence of 3 or more hemodynamically stable VT within 24 hours, or a VT which recurs within 5 minutes of termination, sustained or non-sustained VT, which results in total number of VT beats or ventricular ectopic beats that is greater than total number of sinus beats in a 24 hour. So basically, that's what I was saying, that in all these definitions, it is basically a generalized myocardial electrical instability, which is the underlying theory. And in patients with ICD, the most widely accepted definition is 3 or more appropriate therapies for ventricular tachyarrhythmia, including ATP or shock within 24 hours. So basically, the actionable definition of an electrical storm is 3 or more episodes of ventricular tachyarrhythmia in 24 hours. However, this definition does not include a patient who has a VT that is slower than the programmed detection rate of the ICD, or a VT that fails to terminate with appropriate ICD therapy and remains undetected by the patient, an incessant VT which is slow and not much symptomatic, a VT that recurs soon after successful therapy may remain undetected because of the slower rate, may not fall into the VT categories. So when we consider an electrical storm or a VT storm, what we see is that in around 85 to 95% of the cases, it is caused by a monomorphic VT. In a way that is for the good only, because monomorphic VTs are more amenable to definitive therapy. VFs in different series can be present in 1 to 21% of cases, and VT-VF in 3 to 15%, polymorphic VT in 2 to 8%. And this meta-analysis published in Europace, it shows that the hazard ratio is around 3.15 in patients who present with an electrical storm. So definitely, as we all are aware, that presence of an electrical storm significantly increases the mortality of these patients. So I'll just skip all those routine etiology part and all, because we know that VT electrical storm is caused by the electrical storm is caused by dyselectrolytemia like hypokalemia and hypomagnesemia. So those are the correctable causes that we can take care of. We should try to correct the hypokalemia, and the target potassium in patients who have ventricular arrhythmias is on the higher side, and target should be between 4.5 to something around 5.5, and the magnesium should be maintained more than 2.5. Then some thyrotoxicosis is sometimes missed. So all such patients should be getting a thyroid profile, including a TSH. Urinary drug screening can be done if a relatively young aged person presents with a VT or electrical storm. Then coronary ischemia is the common cause, as in everywhere in the world, it is a common cause of electrical storm. So coronary ischemia should be evaluated and treated emergently. Once these correctable causes are taken care of, then comes the support, because what we have seen is that electrical instability mostly presents with serious underlying heart disease. Most of these patients have serious structural heart disease. And the problem is the most common therapy that we start is inotrope to maintain the hemodynamics. However, inotropes are known to worsen electrical stability. So as when it comes to hemodynamic support of these patients, the inotropes should be coming lower down in the preference. Our first preference should be non-pharmacological or mechanical circulatory support. And the most readily available is IABP. So intra-aortic balloon pulsation should be immediately instituted when a patient has LV dysfunction or heart failure and presents with significant electrical storm. Then ECMO also is available now in many centers. Post-COVID, many centers have ECMO. So ECMO is another option. Impella is very available in very few places in India. And also Impella is not that much favored because the Impella catheter might itself be pro-arrhythmic in these patients because of the general irritability of the myocardium. So the point here I want to stress is that inotrope should be lower down, and the mechanical circulatory support, at least an IABP should be immediately put to support these patients. Then next, another very important aspect is sedate. So sedation is available in the form of, we can give oral benzodiazepines, we can give Dexmed, opioid analgesics, and lastly, general anesthesia. There was this very interesting paper published in Circulation where they have actually done a detailed analysis of the deep sedation in patients who present with electrical storm. And there was interesting finding that Dexmed was actually found to be superior to propofol and somewhat superior to morphine. So this is an important observation, because Dexmed, especially in some of the hospital settings, it is very difficult to get morphine. However, Dexmed is a better choice in such patients, and Dexmed is readily available in most of the pharmacies. We can give a bolus dose of Dexmed, that is 0.5 microgram per kg bolus, and which can be followed by 0.5 microgram per kg per hour infusion, and can be increased to 60 microgram per hour infusion. And that gives a good level of sedation without causing hemodynamic compromise, without causing much of respiratory compromise. So Dexmed should be our preferred sedative in such patients. So that's what the first three things we should do is we should try to correct the correctable causes, then we should try to support the circulation, and we should try to sedate the patient. So that will give the initial stabilization of these patients. And what this, again, the same Circulation papers comes up with a very interesting figure that in patients where we are able to achieve deep sedation within 15 minutes, we see acute termination in a majority of the cases, and there is a 55% lower risk of in-hospital mortality in such cases. So that tells us about the importance of deep sedation in such patients who present with significant electrical instability or electrical storm. And when there is no acute termination after deep sedation, we can consider hemodynamic support, mechanical circulatory support, neuraxial modulation, or urgent catheter ablation. Once we achieve the initial stabilization, then the step 2 is evaluation. So after stabilization and patients who present with unstable pulseless activity, they should be stabilized with the ACLS protocol. And after that, most of these cases, majority of these cases will have structural heart disease. If structural heart disease is not there, then we have to evaluate for specific subgroup. Specific subgroups are a totally different ball game because they have the genetic arrhythmia syndromes and all. They are rare and they present a different category of problems. However, our most common category of patients are patients with structural heart disease. And when the patients with structural heart disease, what we have to see is whether there is an active low output state, or there is, if the active low output state is there, like patient is having reduced urine output, or on the ABG we see that the lactate levels are increasing. The mental status we cannot assess because we already have sedated these patients. In those cases, our priority should be to aggressively support hemodynamically to such cases. That should be the priority before we go into other therapies. So hemodynamic support is most important when there is an active low output, because once there is a low output state, the vicious cycle actually sets in, where any further events will again further lower the cardiac output, will cause more myocardial stunning, and ultimately the outcome of such patients becomes very worse. So that's why if there is any evidence of active low cardiac output, we should go for an aggressive hemodynamic support. And once we have taken care of that, next part comes the medication, the devices. Why device troubleshooting? Because ICDs have a survival bias. What happens is most of these patients with electrical storm, they may not survive up to the hospital emergency. So ICDs, they definitely do not take care of the electrical storm. However, they help the patient to survive till they get in contact with the healthcare system. So basic medical therapy usually consists of propranolol. There was a meta-analysis published in, I think, JACC in 2018, where it was compared that oral propranolol 40 mg 6 hourly versus metoprolol 50 mg 6 hourly. Metoprolol for 50 mg 6 hourly is also a very high dose in such patients. And it was found that propranolol was far better when it comes to free from electrical storm or in hospital mortality or hospital discharge rate. Amiodarone is definitely the most broad spectrum antiarrhythmic available, and the dose that we usually practice in PGI, that is the standard dose, like 150 mg given slow IV over 10 minutes, followed by 1 mg per minute for 6 hours, and then 0.5 mg. Lidocaine can be given 100 mg to 150 mg bolus, followed by 1 to 4 mg per minute. So these are the standard therapy, and this is the JACC article where we see that there is a survival benefit with propranolol as compared to metoprolol. Once these antiarrhythmic drugs are instituted, and since many of these patients will be having devices, we need to look into the device also. So this table is a busy table. There is no meaning. This is just the standard programming parameter that is given by all these companies. However, when a patient presents with electrical storm, we just have to change these programming parameters. Some of these programming parameters need to be altered, reprogrammed. So few of the programming parameters that should be considered is we should try to set a higher heart rate threshold. Usually, this is an observation. This was an article published. It is a relatively old article. Still, the observations are very relevant. Usually, patients treated with primary prevention ICDs, they tend to develop fast VT. So, such patients may benefit from a higher rate detection zone. So, the detection zones can be programmed at a higher rate in such cases, primary prevention ICDs. And patients who are treated with secondary prevention ICDs usually have a slower VT. However, there is a wider overlap with supraventricular arrhythmias. So they can have a slower rate detection zones, but we should give more stress into the SVT discrimination algorithms in patients who have a slower, who have a secondary prevention ICD. So 3 trials like the PREPARE, the MEDITREAT and PROVIDE, they provide us the information that higher detection zones reduce ICD shock without causing increase in syncope or death risk. Just for our reference, everybody, all of us are aware of this. However, just for a quick reference, this was the MEDITREAT protocol, and what we see in the MEDITREAT, this is the conventional arm, and the high rate arm is that up 170, the zone 1 is the monitor only, there is no therapy, and zone 2 more than 200, there is a 2.5 seconds delay, then ATP and shock, and zone 3 is, arm C, there was 170 at rate of more than 170, the delay is 60 seconds before institution of therapy, and then the rhythm ID detection, enhancements, ATP, shock. Zone 2, 200, there is a delay of 12 seconds, whereas in the conventional programming, the delays are usually 6 seconds, 2.5 and 1 seconds. And here, the programming, the detection delay is increased, and this was shown to reduce the number of shocks without increasing mortality or without increasing in the number of syncope. And all the different companies trials that we different brands that have been tried in all these trials, there it has been shown, to summarize just that the higher rate cutoffs and longer detection intervals, they have resulted in lesser number of shocks, and they have resulted in they have not resulted in excess mortality or syncope. Then ATP therapies can be programmed in the when we do the interrogation for such patients, and as ATPs can terminate regular BTs up to maybe 300 with 75% efficacy and 94% efficacy with 3 ATP trains. And ATP should be programmed for rates at least up to 250, and below that rate, maybe we can program a separate zone. And above this rate threshold, the ATP should be there. I mean, there should be ATP during shock. During shock charging, sorry. So these structural heart disease evaluations and medical management and device programming as the initial part. Then let's talk a little bit about the specific subgroup which we sometimes encounter, like long QT syndromes. They can present with a electrical storm, and usually the standard therapy is, if the genetics is known, it's okay. If the genetics is not known, then beta blocker. There is pacing if there is a bradycardia induced VT, toxin evaluation, then sympathetic blockade. And if the genetics is known, we can give specific therapy like flecainide for long QT3. Then idiopathic VF, usually they are the worst kind of VF. I have one case, I will show that, where most of the drugs, sometimes they do not act, like quinidine, then sympathetic blockade, and PVC, if it is, the storm is triggered by a PVC, that is one of the rare incidences where it can be curable. If we ablate the PVC, then we can take care of the idiopathic VF. Some of the other escalation therapy that have been tried, personally I have never tried ibutilide, but there are reports that ibutilide has been tried, and the number of shocks 24-hour post ibutilide, I mean the number of shocks 24-hour before ibutilide was something like 35, 11, 15, and post ibutilide the number of shocks have been significantly less, either 0, 1 or 2. And the number of doses given ranges from 2 to 9 doses, 1 milligram. I'm not sure about the gap, at what intervals they have given those doses. But this is a very interesting finding, because so far our knowledge was that ibutilide is given for paroxysmal atrial fibrillation, but it can be tried in patients with electrical storm, which is not responding to our conventional drug therapy. Neuromodulation, we know that the stellate ganglion blockade is a effective therapy in patients, especially with refractory VTVF. And in my hospital setting, we have a pain consultant who is a consultant in pain therapy. And he usually does these ultrasound guided stellate ganglion blockade, especially on the left side. It's not a permanent blockade. What they do is a temporary block, and then like all storm passes, so electrical storm also usually subsides 48 to 72 hours. So that gives us a lot of time to stabilize the patient and to tide over the crisis. So neuromodulation is an important part in these patients who are refractory to the first and second line of therapy. Then thoracic epidural anesthesia has been seen, and as we see from this paper that was published recently, that VTVF episodes after thoracic epidural anesthesia has significantly come down, almost to zero. So that's remarkable actually. I don't know, I have no personal experience, I've just read this paper, and there is significant reduction with of VTVF episodes after thoracic epidural anesthesia. So we can always take help of our anesthesia colleagues in refractory cases. Then renal artery denervation has also been tried in some of these refractory cases, and the clinical outcomes, that short-term ventricular arrhythmia recurrence rate have come down to a very low level. Long-term arrhythmia-free survival is something maybe 10%. All-cause mortality was also reduced. So, and there are some reports that there are some reports available. There are data or evidence is available that renal denervation therapy might actually work in refractory cases by reducing the sympathetic tone, the overall general sympathetic tone of the body. Similarly, stereotactic body radiation, I would like to hear others' opinion about this, because I don't know whether this therapy is available in India or not. However, this paper is from the United States, where the stereotactic body radiation, the stereotactic radiation therapy has been shown to be very effective in such cases, and there is a reduction in the number of device-treated VTVF episodes in these cases. Now comes the catheter ablation. Catheter ablation is like one of the final frontiers of this therapy. However, we have to achieve a certain degree of hemodynamic stability, a certain degree of stability to these patients, because as we know that catheter ablation is a lengthy process. It takes some time, and the patient has to be in the lab for a longer time with so many other complications. That's why we need to, ideally, we need to achieve some degree of stability before we take up the patient for catheter ablation. And factors that favor ablation are the monomorphic VT, because those VTs are sometimes easy to localize, relatively easier to localize and ablate. We can go for a channel ablation, we can go for a scar homogenization, we can go for a border zone ablation, core isolation. So many strategies are there. Underlying ischemic cardiomyopathy is more responsive to catheter ablation rather than non-ischemic cardiomyopathy, because as we know, the non-ischemic cardiomyopathy, the substrate for ablation will be more patchy and more diffuse in distribution, endocardial, epicardial, patchy substrates. Whereas in ischemic, we get one transmural infarct with some border zone and some low voltage areas in the border zone, some islands may be there. Unifocal PVC-induced arrhythmia is relatively, safer and relatively easier, because we have to localize the PVC and ablate. It helps that the, when the arrhythmia storm has settled, but there is a risk of recurrence. So once the arrhythmia storm is settled, we get certain degree of stability, and then we can take up the patient for reducing the number of recurrences. Some studies are available to show that there is a role of catheter ablation in electrical storm, especially in electrical storm. The number of patients are not great number. Most of the series are small and reporting some 20 to 50 cases, or a few large series have been reported. And all of these cases have included patients with LV dysfunction. And in the acute suppression of the electrical storm, what we see is that up to 100% of the patients, they can achieve acute suppression. And the lowest reported success rate is around 50%. So, I mean, in a good amount of, in majority of the patients, we can get an acute suppression of electrical storm with catheter ablation, and recurrence rate, like all VTs, all scar VTs and non-ischemic VTs, the recurrence rates ranges from something around 25 to 50%. However, the recurrence of electrical storm definitely goes down. VT might recur. However, the chances of again developing an electrical storm is significantly lower with catheter ablation. And based on these findings, catheter ablation is a patient who had just died over the storm should be strongly considered. Then this was one of the large trial published in NEJM. Everybody might have gone through this, the Venice trial. However, it was not a specifically trial of electrical storm, but this was a trial where it was shown that in patients with ischemic cardiomyopathy and an ICD who had ventricular tachycardia, catheter ablation was associated with a lower rate of death, ventricular tachycardia storm, or ICD shock at around 2.5 years of follow-up, as compared to escalation of drug therapy. So probability of event-free survival, probability of overall survival, probability of appropriate ICD shocks and lower appropriate ICD shocks and VT storm was significantly low with catheter ablation. So that gives enough proof to consider catheter ablation in these cases. And in the subgroup analysis, we see that in most of the subgroups, whether age, sex, and rate of VT, then functional class, in most of these subgroups, even ejection fraction, the catheter ablation was found to be better than dose escalation. And this trial was, it was kind of an important trial. And based on this trial, the 2017 guidelines of catheter ablation of ventricular tachycardia also gives a class 1 recommendation for catheter ablation in patients who are receiving ICD shocks. However, when we take up these high-risk patients, there are few predictors that these patients might require hemodynamic support during catheter ablation. And the total score can go up to 35. And the scores more than 9, they predict the chances of need for a mechanical circulatory support. So whenever we are planning for a high-risk catheter ablation in a patient with significant LV dysfunction, we should always prepare for or plan for hemodynamic support. Maybe IABP that is available in most of our centers. IABP at least we should try to have cover up. So like presence of COPD, age, ischemic cardiomyopathy, NYH class 3 or 4, ejection fraction less than 25%, history of VT storm, and diabetes mellitus. So these are the predictors that have been developed by the Santengali group. I would like to show 1 or 2 cases of mine. So this was a patient who had ischemic cardiomyopathy who was post CRTD and present with multiple shocks, some 13 shocks in 2-3 days, and monomorphic VT was inducible in the cath lab. There was some, I went for an epicardial also in this case because there was some literature that epicardial endoepicardial mapping may increase the long-term outcome. And after we did the endo and epicardial mapping, so this was the baseline echo showing severe LV dysfunction. We also did ICE because the LV was very dilated. So it was not sure that whether we are actually touching the areas or we are going for spuriously low voltage areas. And then where there was isochronal crowding, we did ablate. And this case was done in March 2020. And so far patient had only one, after that patient had received 1 shock and 1 anti-tachycardia pacing. So he is relatively now stable and happy with the result. This was another case, again presented with electrical storm, multiple shocks, case of ARVC. And like the classical ARVC, what we see is that the QRS duration in the V1 to V3 is longer than the QRS duration in V4 to V6. So it was a classical case of ARVC, MRI proven, RARV dilated, post ICD, presented with multiple shocks. And here also we did epicardial, because ARVC we know is that epicardial to endocardial disease. Most of the substrate is epicardial, and this disease was fairly advanced disease because structural change was there. There was complete RBBB, which are predictors of pretty advanced substrate in these cases. And we found that there was basal substrate. I would like to show the voltage. So these are all the delayed potentials in the endocardial areas, and then delayed potentials in the epicardial mapping. Also, we found very good, nice, discrete potentials here, and we targeted all these areas. The propagation map was also correlating with these findings. So finally, we ablated, and he is now shock-free for last 1 year. Patient is the drug therapy includes metoprolol 100 mg twice daily. But patient is now shock-free for last 1 year, so he is happy. So these are the final ablation lesions. This was a very interesting case. Like I was saying, the idiopathic here. This is a patient, a 21-year-old male who had early repolarization syndrome. So there's a J-point elevation part. So this is now called J-wave syndrome. So there is a J-point elevation, and he presented with VF. Multiple episodes of VF. He was very lucky to reach the hospital the first time. And once we diagnosed him as a idiopathic VF, actually ICD was implanted. After that, multiple anti-arrhythmic drugs were tried. However, he was getting regular ICD shocks. So I discussed this case with many authorities also. And then I thought that everybody advised that a cardiac MRI was normal. There was no scar, nothing on the cardiac MRI. So I took up the case, and endocardial, epicardial, both sides we tried to map, and we found some, I'll show, some delayed potentials were there, not like the ARVC delayed potentials, but there was some lava, local abnormal ventricular activations. So I tried to target all those areas. These are the epicardial areas, some basal border zones. However, after ablation, the patient, the number of shocks, according to the patient, the number of shocks have come down. Even previously, he was getting an average of 4 or 5 shocks in a month. Now he gets 1 or 2 shocks, and I mean, in a way, he is also accustomed to his shock. But his battery needs replacement. In 2 years, his battery drained out actually. So this is the latest ECG. When we compared with it with the initial ECG, I don't find these clear humps, the J points. However, there is ST elevation is still there. I don't know how he will do in the long term. I have to see. So combining all these types of cardiac problems in the electrical storm patients, the assuming medication, hemodynamic support, and there is no reversible factor, the chances of success according to the etiology. If it is a non-ischemic cardiomyopathy, shock, prior ablations, patient presents with VT or polymorphic VT or VF, then neural modulation has the highest role in these cases. Then stereotactic body radiation and ablation is less important. If the patient presents with ischemic cardiomyopathy, no revascularization, monomorphic VT, then ablation is very important. Stereotactic body radiation is important. Then neural modulation is less contributory in these cases. In patients with ischemic cardiomyopathy, no revascularization who present with VT, who present with VF or polymorphic VT, probably stereotactic radiation is more efficacious in this, and then neural modulation and ablation. In patients who are already on LVADs, who are non-ischemic cardiomyopathy, history of prior ablation, and monomorphic VT, their stereotactic radiations, neural modulation, and ablations. So to summarize everything, when a patient presents with electrical storm, we should try to resuscitate the patient, then initial try to correct, support, go for a drug therapy, then go for therapy escalation in terms of neural modulation, and catheter ablation whenever feasible. Thank you.
Yeah, Anupam, that was a great presentation, made many things clear, even, and I think this would be followed by a great discussion. One thing we that I had experienced during my DM training was we had a very elderly person admitted in PGI, and his son was in US, and he had a VT storm, maybe giving the ICD gave around 40 shocks in 24 hours, and probably that deteriorated the patient, made him worse. Then the son came and requested that, switch off the ICD and let him die peacefully. So this is one of the cases where what would you suggest when we should stop, or how we could have helped that patient?
The first thing is to immediately place a magnet on the ICD to stop the shocks. And then because this, even if the VT does not kill him, the shocks might kill him. So we should just place a magnet and see what is happening actually, whether the VTs are tolerated or not. If they're, because we have other things, we can immediately go for a deep sedation, we can immediately go for correct. So sedation is one thing which is sometimes neglected, but rapid sequence induction with deep sedation is, I think, the first line of therapy. Apart from, of course, doing an ABG to immediately look for the potassium or to look for the hemodynamic cardiac output status, low output status.
So that was a great presentation, Anupam, and thank you for also sharing your cases. Some of the cases that you shared, very impressive to see that the kind of work you are doing, and both in terms of substrate modification, in terms of epicardial, endocardial ablation. So I think that you pretty thoroughly covered every aspect, all the way from drug therapy to ablative therapy to neuromodulation and radiotherapy, stereotactic, and including the role of sedation. But I think, I'm not the right person to answer this or understand this, but I think a lot of what you do also depends upon what your local expertise and availability is, which I think may be a challenge for many people on the forum, and understanding where exactly you have a system where you say, this is the point beyond which my institute or my center or my organization cannot offer. Because a lot of the things that you mentioned, they're not always easily available, and not easily accessible to every institute or every organization or every patient. So on one hand, I think it's very important to know the gamut of therapies that are available, but it's also important to know what is the risk-benefit ratio and long-term outcome with every option that is available. Because you have to ultimately find out in a lot of these patients who are very sick as to where do you say that you stop, just as the case that Smit mentioned. Because, a lot of these things can then become theoretical, and we have to see what they are of value in that individual patient. And that is where I think it also becomes very important in a lot of these patients to understand where exactly you have that discussion with the family or the patient regarding what are your goals of care, what is your ultimate prognosis in that individual patient, and where do you exactly draw the line between feasibility and practicality. So I think a lot of it depends upon what the audience has as far as questions in mind. But among the cases that you presented, I was just curious about that one patient that you presented with early repolarization.
Yes.
So, because it seems that the patient is still getting shocked.
Yes, sir.
What exactly is the medical therapy that you are doing for that patient in terms of anti-arrhythmic drugs and your other thoughts in that situation, because the patient seems to be young and seems to be still suffering from a high morbidity.
Sir, so initially I tried propranolol, so 40 mg QID, then added amiodarone, added maxilatin, but I don't know. I tried getting quinidine. I think that one company is providing quinidine in India. Gopi sir, if you have any idea, I could not procure it actually. Maybe quinidine might have worked. But maxilatin, amiodarone, and now I have switched to metoprolol, 100 mg twice daily, 200 mg per day. His number of shocks have little come down, but still he gets on average 1 to 2 shocks in a month.
See, the reason that I ask is that, you know, when I kind of look at, I mean, if I have to summarize for somebody who has more of a general cardiology or interventional background, because I know that even from my practice in India when I was there, and even now when I see the general trend, you know, in India, there are, if I understand right, and you can correct me if I'm wrong, there are very few centers which have specialized electrophysiologists. So I think one of the very important part of this talk could be to see how to empower somebody who is actually not a trained or specialized electrophysiologist and feeling that, you know, he is able to offer the best for his patient. So as you rightly pointed out, you know, you have to differentiate between patients who have a polymorphic VT-VF kind of a situation versus monomorphic VT-VF, monomorphic VT situation. So it's kind of like the trigger and the substrate theory,
Yes,
but
sir.
if you understand the basic physiology, you either are dealing with a situation which is increased automaticity, which is not usually what you're dealing with in storms, because that is most often the situation in people with structurally normal hearts, where you have RVOT, VTs and things like that. Or you're dealing with a situation where there is triggered activity or re-entry. Re-entry is most often the situation where you have a mature scar, most often in patients with ischemic cardiomyopathy, but very often in patients with non-ischemic cardiomyopathy. And in non-ischemic cardiomyopathy, the scars are just different. They are still mostly endocardial, but more often epicardial or mid-myocardial. And that is what makes ablation a difficult option for them. But in ischemic cardiomyopathy also, it's most often, you know, it's most often endocardial. A lot of them may have epicardial components in the circuit, but they have an endocardial element that you can target. So just like you mentioned the case that you tried to go epicardial and endocardial. So although people talk about going epicardial, most often you can get some endocardial portion, or even when you're very annular, you're better off ablating endocardial because it is not easy to access those annular areas epicardially because of fat, or many times you may have adhesions from previous infarctions, or a lot of these patients may have had a previous bypass surgery or a previous open heart surgery, which makes it very hard to go epicardial. So all those things are good for the books and case reports and for flouting those things. But in general, you know, at least my experience is that, you know, most patients with ischemic cardiomyopathy, you do not get that bang for the buck for going epicardial as liberally as it may be in very rare presentations and sometimes even manuscripts, you know. However, when you're thinking of drugs, you know, you think of either sodium channel blockers or potassium channel blockers. And sodium channel blockers are more likely to affect the trigger, and potassium channel blockers are more likely to affect the substrate. And potassium channel blockers would be drugs like sotalol, drugs like amiodarone. Amiodarone is actually both a potassium channel blocker, IKS blocker, and also a sodium channel blocker, but a weak sodium channel blocker. And drugs like flecainide and propafenone are more like sodium channel blockers, so they are more important for automatic VT and affect the trigger. But when you're dealing with the VF and polymorphic VT, you know, the myocardium does not like a situation which is, inhomogeneous, if I may put it like that. So either you have completely normal myocardium or completely dead myocardium, But when you're in that phase where you're having a maturing scar, ischemia, dyselectrolytemia, that's when you have what we call this phase, what we call as dispersion of refractoriness. So that means every single area has its own refractory period. So you're kind of creating a milieu for functional reentry in small little circuits, and that is what causes VF. So again, making that homogeneity, whether it is by improving ischemia, improving dyselectrolytemia, improving blood flow, is important. So, if we kind of think that way, that in one situation you have an organized scar and re-entry, and you try to break the circuit by either making the substrate less fertile, slower, or completely demolish it by an ablation, your chances are good of working on this with an ablation. Or you have a situation where you have kind of many different areas of rotors or re-entry, or whether it is functional or whatever, but it is more from a generalized destabilization of the whole myocardium. Then unless you have a focal trigger like you have in a PVC-induced VF, you're not going to be able to make a difference on the substrate by something like an ablation, and you're going to more likely make a difference by something more diffuse, whether it is revascularization, whether it is general improvement in circulation, whether it is distal electrolytemia, or whether it is drugs, because that works everywhere rather than in a focal place. And then you have the third situation where you have specific situation, whether it is Brugada, whether it is long QT, whether it is early repolarization, whether it is CPVT, where in those situations, the mechanism is totally different and you have to tailor to that specific therapy. So it is very interesting that case you mentioned of early repolarization syndrome, because it's important to understand that those patients fall into the J-wave syndrome because they are probably a different pattern where, although even in Brugada, we think about sodium channel being a problem, it is more of a gradient that happens between the epicardium and the endocardium because of the ITO channels being more of a problem. And the transient outward current, is what is a problem. And that is what, if you block with quinidine, can have a remarkable effect. So it's unfortunate that you don't have access to quinidine, but I would be inquisitive or curious to know what happens to the use of quinidine in that patient. And what I kind of find concerning is that, sodium channel blockade can be a problem. And so, for example, amiodarone is a sodium channel blocker, though a weak sodium channel blocker. So that could be a problem. Even your mexilidine combination. So I don't know whether it is helping the patient or hurting the patient. And we'll know less about early repolarization than we know about Brugada. But if you look at the drugs that should be avoided in Brugada, which is a very similar pathology, and that is why it has been clubbed into the same category as J-wave syndromes. If you go to this website called brugadadrugs.org, that is the website that tells you which are the drugs you should avoid for Brugada syndrome, then actually some of the beta blockers are also into that. So it becomes a big challenge to manage patients like yours, because, in Brugada syndrome, ideally, you should be avoiding drugs like lidocaine. I sometimes get a lot of concerns from even dentists and things like that, oh, I have this patient who has Brugada syndrome and I need to do a dental extraction on him. What anesthetic can I use? But if you look into the literature, there have been certain cardiac deaths with drugs like bupivacaine, but lidocaine has been safer, but is not completely risk-free, and people are scared to give it here because of their sodium channel blockade properties. So it's something that I would be very curious to learn from you even later as this patient matures. I hope you can get access to quinidine and try it. But I think that might be an interesting thing to see in this patient. I don't know that I have understanding of a situation like this in an early repolarization syndrome patient, but I think physiologically that would make sense.
Thank you, sir.
So I don't know how many people are on the call, but I just want to learn from other people what their thoughts and experiences and questions are, because Smith, I think you're muted. You're trying to speak, but we can't hear you.
Anupam, can I make a point?
Yeah, I can hear you.
Yeah, so that was a very comprehensive talk on almost every aspect of VT storm, including really very tough, complex cases. Very few centers do epicardial VT ablation in our country, and both of the cases were very interesting. Just to add on with what Sir said, actually, we don't have quinidine, but actually, if you look, there are some local manufacturers. It actually goes out from India only to the abroad as well. Quinidine actually is getting manufactured in India only, but we find it difficult to procure it, and we have actually tried quinine instead of that with some partial success, but actually it was mostly tried for the Brugada patients who had repeated ICD shocks, for whom we had tried quinine with some partial success. Just taking a clue from extrapolation of Brugada, actually in Brugada storm, that in Brugada patient with electrical storm, the drug of choice actually is isopranaline infusion actually. Yeah. So in such a scenario, could you extrapolate to all the J-wave syndromes? I'm not very sure actually. I would like to have inputs from Mandeep sir as well about whether if you can extrapolate the role. This is probably one scenario where isopranaline infusion is really the treatment of choice in a VT storm. Like if you have a Brugada patient coming with a VT storm, so would it be of any use in similar J-wave syndromes? What do you think actually?
I mean, I can't speak to the fact that I can tell you that I have treated many patients with early repolarization with ICD storms, to be honest. But these patients, they have very few occasional shocks, and usually we don't need any long-term suppressive therapy. Isopranaline, yes, can be very useful, but then you can't send the patient home on isopranaline. Yes. You have to transition to some kind of oral therapy. And I mean, I've had situations with Brugada syndrome very often, where sometimes, in fact, we had a patient from Saudi Arabia, and they were pumping amiodarone in him. And when he had an ICD placed, there was not a very obvious Brugada syndrome in him, very, very subtle right bundle branch block. But when he got amiodarone for his shocks, he had a very, very obvious Brugada pattern. And then, amiodarone is a slow acting drug and it's slow to come off. And even when we stopped the amiodarone, he was just having shocks. So we went and did an ablation for the epicardium in the RVOT, just as has been shown for Brugada, and that patient got better. His Brugada pattern got better. Now, if you have to see it physiologically, one would tend to think that it is presumed that you have the same physiology, but not in the RVOT. So that's why you don't have the changes in leads V1 and V2, but you have the changes in leads 1 AVL and 2,3 AVF, because you're dealing with the same physiology probably in J-wave syndromes, the early repolarization, similar to Brugada. So I would not hesitate to use isopranaline and see what happens in an acute stage. But my concern is more for Anupam's patient who's getting 2 shocks a month. And I don't know if in that situation, amiodarone and mexilidine are doing good for him or not. Now, I know you went and ablated, which is obviously a thing which would come to mind when you're dealing with a difficult situation like that. I don't know if you ablated epicardially or endocardially, but these changes happen very close to the annulus, and very close to the annulus, even epicardial, you have a lot of fat. So even if you get there, and even if you deliver energy, a lot of the energy is not going into the myocardium because the fat is insulating it. So many times you are able to get better energy delivery endocardially. But again, I can't tell you that this is a very standard form of therapy for early repolarization. So I can understand your frustration dealing with the patient and trying whatever you can. But with a young guy like that, I think I would probably try quinidine and see what happens. And if I'm not, I cannot tell you I have much experience in using quinine. But yes, physiologically, it makes sense that a higher dose of quinine may have similar impact and similar anti-arrhythmic properties. But, we are always constrained by the use of drugs unless they are FDA approved. And you have a more liberal atmosphere to do that in India, but I can't tell you how useful that will be. So, but again, in that situation, when you ablate.
Sir, you are muted. Sir, you got muted.
Sorry, I don't know where I left,
Liberal use of drugs.
Yeah, so I mean, I was just curious to know where exactly you ablated, endocardially, epicardially, and I know you were trying to show some change in the ST elevation, but
I don't know. So, I mean, it was near the base only, sir, more towards the annulus, not the apical part. So, one was in the anterolateral part. I got some abnormal signals, so probably corresponding with the ST elevation in one AVL and other leads. I just want to add one point. Now that we are discussing, a thought came to in my mind that if isoprenaline can be given in the acute setting, how about trying oral orciprenaline in this patient? Maybe I can try that. I don't know. Maybe we can. That thought came to my mind now.
Anupam, does device lock show any triggers? Actually, any muscle PVC, no Purkinje PVC, no triggers.
No, I could not find it. Otherwise, I would have first ablated that. I could not find anything. Just degenerates into VF.
So I think, the basic, the other few points that I wanted to highlight is that, few of the things that I see often happening randomly is that, how you use drugs also is very important in patients with VT storms. And for example, I see even here also sometimes people are just pumping intravenous amiodarone. I think in most patients, it's very important to understand that, the bioavailability of intravenous amiodarone and oral amiodarone is very similar. And intravenous amiodarone can be very, very thrombophlebitic. And if you can use oral amiodarone in a stable patient, you're not really losing out on a lot. And I don't know about India, but at least here, intravenous amiodarone is much more expensive than oral amiodarone. And in a lot of the situations that we practically deal with, I mean, we are talking about early repolarization, Brugada and all, but these are all less common situations. Most people will be dealing with situations which are acute, whether it is acute VTVF in the setting of an MI that they would be dealing with, or post-infarction patients with ischemic cardiomyopathy. So I was just curious to know that the audience that we have, do they have specific things that they face as challenges? Because it would be more important to address the questions that they have rather than to be able to see what is possible in the world of VTVF at this point of time.
I think one of the important, many of us will be facing is the post-MI VT storms after some time. That is a common scenario that happens. So, sir, what is your opinion about overdrive pacing? Because personally, I don't find it, unless it is a previously triggered VF storm or something, overdrive pacing, sometimes it helps.
It may help in the acute setting, but then you're waiting for something to stabilize. So if you're dealing with a myocardium which has just infarcted 24 hours ago, and you're dealing with very frequent PVCs and recurrent shocks, and you do overdrive pacing for 48 hours, 72 hours, you wait for the scar to mature, you wait for the revascularization arrhythmias to settle down, the revascularization impact to take over, then that is fine. But it cannot be a long-term strategy, and you have to have something definitive come over. And in those patients, you are looking at how much of your problem is electrical, how much of it is mechanical. And some of these patients, like, you mentioned about the Painsd score by Santangeli and things like that. But if you look at that paper, it did not really improve outcomes in terms of the way they wanted. And still, if you talk to Marshalinski or Santangeli, many times the question is, which patient do you ablate and try to revive by improving his ventricular arrhythmia, and which of those patients who's so sick do you really go for a transplant directly because their basic pump failure is so bad that whatever you do from a ventricular arrhythmia perspective, because you lose out a lot on the hemodynamic support aspect by other collateral complications. You put in these impellas, the 3O impella is not so useful. The 5O impella has to be put in by the surgeon through the axillary route. Our own experience has been that a lot of these patients, you end up having difficulty mapping those patients. Even with a 5O impella, you can't get that support from mapping that you have from an ECMO and an LVAD. So in a few of the slower VTs or in very sick patients, the impella might help, but not in everybody. And then some of them you have problems from the impella also, hematomas, infections, complications. So you have to balance that center by center and patient by patient. And sometimes a substrate mapping may be more useful because it gives you the ability to map in sinus rhythm than try to just, do an activation map and do it in the very more conventional way of VT mapping and ablation. So I think you have to make that choice in every individual patient very carefully, depending upon what is the ejection fraction, what is the hemodynamic status, what is the compensation level of that patient from a heart failure standpoint, what is the rate of the VT, how many VTs you're dealing with, how stable is the VT, what the other comorbidities are in terms of renal failure and other things. What is his transplant status? What are his transplant or other advanced heart failure options in terms of an LVAD or an artificial heart? So when we see a patient like this, we usually have a team of 3 people, the electrophysiologist, the heart failure doctor, the surgeon, all involved in the decision making, because they all have to be coordinating that thought process very well to see what is the risk benefit ratio of an ablation in that patient.
So another point that sometimes comes to mind is somebody who post MI who has an electrical storm or VT storm, and there is a LV dysfunction. Then that waiting period of 40 days, because wearable ICD is an alternative which is not available. Even if it is available, it is very expensive. So what is your advice about early ICD in such cases who have survived a storm and now in the first month of the MI?
I mean, if they've survived a storm, then really you have to see that if the patient has really had secondary ventricular arrhythmias, that means he's had arrhythmias beyond the first 48 hours or sometimes even 24 hours of an MI. For me, that patient becomes secondary prophylaxis. So this is not primary prophylaxis. So there is no point waiting for 40 days.
Yes, sir, yes, sir.
That's
So
only
that
for
patient, that patient needs an ICD.
Yeah, 40 days is only for primary prevention.
Yeah, so that's only for primary prevention. Now, if you put in an ICD, then again, that is not going to prevent the recurrence of arrhythmias. So you have to make a distinction between which patient you think has been revascularized in time, and he will have a progressive improvement in his myocardial function recovery and is just having hibernating myocardium, versus which patient you actually revascularized late enough that you're not expecting much. So you have to decide how much of your scar is in evolution and how much of your scar is in resolution.
Yeah.
And that is what is going to give you an idea clinically as to what is the risk of recurrence in this patient. And that is how you make the decision whether you give amiodarone to that patient or just wait on guideline-directed medical therapy. That is what helps you decide. Now, you really want to avoid an ablation in the first 6 to 12 weeks because the scar is very mushy. When we've done that, sometimes even unknowingly, where the infarct age is really short or long, we've sometimes had perforations because of the very mushy myocardium. And even when they have a perforation, it's not a happy situation because it's not easy for the surgeon to repair very friable myocardium.
Exactly.
So my personal bias would be to really avoid an ablation in the setting of an acute MI, at least for about 6 to 12 weeks. You also have to understand a lot of these patients which look like monomorphic VT are not really monomorphic. They're almost like a ventricular flutter or looking monomorphic, which degenerate into a polymorphic VT. So you really want to try and control them with medical therapy as best as you can. I mean, one time I remember we had a patient where we had to keep him under anesthesia for almost 35, 40 days because every time we tried to wake him up, he would have a storm. The first time, about 7 days post MI, we took him for an ablation for a PVC induced VF and ablated the PVC, but still, he would still have a lot of VT. And then finally, after about 6 weeks or so, when the scar matured, then we took him, and by that time his myocardial function was bad and he already had an LVAD, but still was having arrhythmias every time he woke up. So after 6 weeks or so, we took him back and did a full substrate modification, isolated the whole scar, which was apical from an LED, and then he stabilized and he's still doing fine, still on the LVAD because he's not a transplant candidate, so he's a destination LVAD. But sometimes when you face the situation, you deal with it the way it comes. But unfortunately, in the acute setting, I don't think ablation gives you that incremental success that you would have from a mature scar. And that is an important thing to know. You know, it's not a word that you just drop anytime that, oh, ablation.
No.
You just can't just throw an ablation anywhere. You have to know. You know, that's why they say that the eyes can
Sir,
only see what the mind knows.
yeah. 3 years back, I faced a very tough situation. Patient with inferior wall MI and RVMI, post PCI, developed storm, and 3 days after intubation, he survived. But then I was very scared that, of course, patient needs an ICD, but where to put the ICD? There is an inferior MI, there is RVMI. If I go more apical, I might perforate the RV myocardium. So, I mean, I chose the septal side. I don't know. What would be your advice? Can I put an, because sometimes, I mean, there is some data that septal defibrillation and apical defibrillation may be a little different.
See, I'll tell you, when do you run into defibrillation problems? You know, these days, if you look at the devices, we don't have those 20, 25 joule devices anymore. All Medtronic devices are 40 joules,
40,
Senju
40,
devices are
yeah.
40 joules,
40 joules.
Boston Scientific is 35 joules. So most devices these days deliver very high energy. Secondly, the problem, if you see where you run into defibrillation, is in patients who have non-ischemic cardiomyopathy, who are having very thick LV mass, like hypertrophic cardiomyopathy. There is some data to show that African Americans have a higher defibrillation threshold. But I don't know how often you would run into a problem with a high defibrillation threshold in a patient with ischemic cardiomyopathy in an Asian population, because these are not patients who have a 7 or 8 centimeter heart, you know. These are patients who have had an acute MI, so their overall LV mass is still small. So before you put the ICD, what I find, and we do it as a standard, all our fellows know that they have to learn it this way, that whenever you put the lead, you look at some area which has good electrograms, and we look at the tracings and the injury current in those areas. And if you have good electrograms, good amplitude, and good injury current, you have good apposition and you have good signals, then that area is good enough for you to put it in. Even if it is a little septal, yes, septally, you know, you're going a little posteriorly, so a defibrillation would be good. But I would still say that even with a single coil lead, it is very rare that I would expect that in Indian population, you would find a problem with high defibrillation thresholds with the current devices, which are 40 joules. So I would not be worried about putting it in the setting of an acute MI. And most of your infarct-related scars are inside out. So the endocardium is more likely to be diseased than the epicardium. So you're not likely to face a situation where, oh, your endocardial voltage is looking good, but the moment you put the screw, it'll go through and cause a perforation because the epicardium has the scar. So most often, if your endocardium is diseased, you will find poor voltages and you won't put it there. So even if you put it sometimes in the outflow, many times if I have put it in the outflow because you don't have good voltages in the apex and you put it in the mid septum or the outflow, 9.5 out of 10 times, I would not expect you to fall into trouble with defibrillation. And you can always do a DFT testing unless the patient is very unstable in terms of his heart failure status.
And we just, if we have a good R wave, good injury current, we don't even do DFTs, even if it is on the septum or outflow. If you have a reasonably good electrogram, good injury current after you have fixed in the screw, it's fine. And most of the time, DFTs are okay. And we only use single coil leads actually. So that is okay.
Yeah, I mean, that is something that, is debatable. And I know after the article from Mike Sweeney from Brigham and all, and Epstein, that has been a contention, but we still do DFT testing in a reasonable number of patients. Like I can tell you, for example, one of my mentors, Dr. Wilkoff, he still probably does DFT testing in at least 90% of his patients for different reasons. But even if I am putting in a defibrillator in somebody, for example, if I'm putting a right-sided device with a single coil, I don't think I would hesitate in doing DFT testing in that patient.
Yeah, that's
if I'm putting a single coil in a non-ischemic cardiomyopathy or a single coil in a hypertrophic cardiomyopathy in a young patient, yes, I want to put in a single coil and avoid a second coil because that would be more fibrosis. But I would not hesitate in doing a DFT testing in that patient. And it's a debatable point as to what are the risks and benefits of DFT testing. But in some of the very sick patients where I think that, we are putting a device, but really that patient's risk of dying from pump failure is so much higher than his dying from ventricular arrhythmias, I think doing DFT testing is putting him through more risk because in the long run, his mortality may still be higher from pump failure, and putting him through DFT and electromechanical dissociation and all that may not be worth it. So again, you use your clinical judgment. You should know the data, but you should treat every patient individually, depending upon how you analyze the data in that particular patient.
Thank you.
Smith, you were making a comment earlier. I'm sorry, you were on mute at that time. I could not hear.
No, that wasn't a really concerned with. Yeah, most of the things that I wanted to ask have been raised, and many things have gone supracortical also. So it was a great talk, sir, and a great discussion. And I'm hopeful that it has, made others get interested into electrophysiology, because during training, probably electrophysiology was just one day a week affair. And now I see that many of our colleagues have taken up as a everyday affair. So we'll have more of these meetings, but next month we have Chhattisgarh CSI conference. So I won't be organizing this monthly meeting next in month of June 26th. And in July, we'll again resume with newer topic. And I would suggest that you take up, Dr. Bhargava, any topic. But we had electrophysiology in the last 2 classes. So probably after a break, we'll have a different topic, and then you can suggest, you can take up a topic here. And in month of July, we'll meet again and we'll fix up a topic.
No, I'll be happy to talk on anything you want me to. I think it would be more appropriate if you decide a topic, because you know the need of what the audience would want. It is better that I talk on something that the audience is interested in rather than something that I am interested in.
Sir, this is a very, very, a varied group, and this is 160 cardiologists with all in different fields. So we usually have around 25 to 40 joining us every month, and maybe less in electrophysiology. So any topic would, sometimes it ignites that interest, and that kindles that fire, and we can start, we can have our colleagues joining in. So
no, I'm happy to speak on any topic, and I think I would once again leave it for. I know it's a lot of effort that you put in personally. I feel bad I missed Arun's talk on physiological pacing last time. There was just some constraints, but I still feel that, I not only appreciate all the effort that you put in, and sometimes I go to these WhatsApp chats and I know things are very actively discussed there. And, we did not have this privilege when I was a fellow. Even if you look at the work that Anupam and Arun and everybody is doing, even when I came here to the clinic and saw a coronary sinus tracing for the first time, that was the first time, because at that time in PGI, there was no electrophysiology at all. You people still have had the fortune of so much more than what was available 20 years ago. And there is definitely really more fun when there is interaction, more fun when there is discussion by more people involved, because it would make more sense to be able to talk and discuss more what the large part of the audience is interested in. So whether it is case-based, whether it is physiology-based, but just talking about fancy things and what is the best that is possible is not always meaningful to the audience. I think it is more meaningful if it is directed towards. So I would leave that responsibility on your shoulders, where I will let you and your coordination with the rest of the team decide as to what you think I could make a contribution in, and that would be my honor and privilege to be able to participate. But I'll be happy to be available, and I appreciate all the effort that not only you put in, but all the participants, because I think one of the things that COVID has done is that it has brought the world closer and has made communication possible among people, which 20 years ago we thought was just not possible, So I think I appreciate all that enthusiasm and the effort. And from all the younger people, even for you guys, I see it is almost like, almost 10 o'clock. And the ability to put in that Saturday evening and put in that time and effort speaks a lot of enthusiasm, which I really applaud. And I'll be happy to be a part of in any way that I can contribute. It'll be my pleasure.
Definitely, sir. We'll pick up a very appropriate and topic for you, and we'll have the class. And for next month, there is no class. In July,
we'll have a discussion, not a class.
Sir, we call it, it's a replica of morning class. So with, everyone as an expert. That is why I asked all of us to join as a panelist rather than as an audience, so that it can be a, real interaction and real one-to-one questions.
Pleasure.
Right, sir.
Thank you once again, Anupam, and pleasure to be here. Thank you.
Thank you, sir.